You just heard the words no one ever wants to hear, a diagnosis. So what happens next? In this conversation, what would you say is the most common mistake that people make right after hearing you have?
As soon as I say you have breast cancer, you get triggered, and nothing I say after that is going to land. The biggest mistake you can make is not being honest with me. I can't afford a week off. If I miss a week, they're going to replace me. Or I'm having more pain than I know what to do with, and if I have a problem with that, we'll discuss it. But if I don't know that's a problem, I can't address it. How are we going to deal with all these things? If finances are a problem, please tell me. I may, at a hospital system, have resources, monies to spend for you.
What would you say are some non-negotiables that every patient should document right away? Labs, visit notes, timelines, insurance contacts.
Theoretically, everybody should be able to review their electronic medical record and be able to say, this is accurate, this is not. What the tool that I would recommend is messaging through my chart or something similar to my chart back to your provider. That's not what I said. That's not what I heard. That's not what I came in for. That's not the diagnosis you told me. When you send those messages to the provider, they become part of your record. So you can dissent right there in writing as a way that permanently be part of the record.
And in terms of clinicians or providers who are listening, what would you say are some small changes that could really make patients feel more empowered from the start?
I work with a lot of doctors who are very much, you will do it my way. You will visit when I say, you will do your labs when it's time to get them done. You will take your medications as I prescribe them. Okay, that worked 50 years ago, right? You and I are now informed consumers. You and I now have options. You and I are going to look for ways to not be treated like that. No one wants to be treated like that anymore. And so if that's still the method that you and your organization employ, okay, you're going to have failures.
Welcome back to Care on the Line, where patient stories meet advocacy in action. In our first episode, we heard how Micah's own frustration with the system became a mission for reform. So today we're getting practical. You just heard the words no one ever wants to hear, a diagnosis. So what happens next? In this conversation, Micah's going to walk us through the first critical days and weeks after a diagnosis, how to organize information, understand your rights, and start building a care roadmap that puts you, the patient, back in control. And I just had a conversation with you a few minutes ago, which I know we wanted to touch on. So I will just allow you to go ahead and speak what's on your mind in terms of advocacy and the world and everything that's going on. So.
Sure. Yeah, and we'll join that conversation in a second. But there's some political things that I'd like to speak to, not in a partisan way. I hope that when we're done with this conversation, I haven't revealed to you who I would vote for in any given race. Okay, I want to be sort of in the middle on this, but I also want you as a patient and provider to be clear about something. You know, our government today is not working; it's not shut down. And on one side, they're trying to prevent health insurance costs from going crazily high and becoming prohibitive. And the other side is saying that they're going to keep things closed and not address this because illegal aliens are using Medicaid and Medicare dollars for healthcare. I want to speak to that piece in particular because aliens, non-resident, most non-Americans absolutely cannot access Medicaid and Medicare. They can't be done. There are certain visas and things they can use and they can enroll, sure. But if they are here without any of that in place, they cannot enroll in government healthcare. They can't do it. The way they do spend money in America is secondary to a law called EMTALA, the Emergency Medical and Labor Act. Something like that. I don't have my notes. Anyway, EMTALA. EMTALA says that if you walk through the door of any hospital that accepts Medicare or accepts payment from Medicare, they are obligated by law to assess and stabilize you. That's what the law says. So, because these people can't get on Medicaid and they can't get on Medicare. And there's nothing else to do when they have a cut or a bruise or pneumonia or trauma or a heart attack. All they can do is walk through the hospital doors and get the care that is required and is mandated by law. That's the law. So when the Speaker of the House comes online and says, these people are illegally using Medicare and Medicaid dollars, they're not. They just aren't. And if you're using that as a pivot point, it's a bastardization of what is real. Now, American taxpayers and American healthcare consumers do have to bear the brunt of those costs. But if we're talking policy, let's keep policy here and healthcare dollars sort of in mind differently, because this policy is not this reality. And so as you're sorting out what's right and what's wrong around this government shutdown, please bear in mind that politicians are very much mixing this all into one big muddy mess. It doesn't have to be that way. All right.
Absolutely.
Okay.
No, thank you. No, thank you for sharing, because there is so much information that is so inaccurate that is just being spread and spewed all over different forms of communication, whether it's the news, whether it's social media, whether it's people speaking on social media that don't know what they're talking about because they read a headline somewhere and take it and run with it. And it is so hurtful and harmful to people that are reliant on these government programs that are in place to help people. And the misconception that is being spread about policies and about these issues and these topics are ruining and destroying these programs for people who need it and rely on it. They were in place to help people. And it's, when we're going to speak about what we're speaking about diagnosis and people's health, and it's just people are getting shut out from the care they need because of misinformation. So you shedding light on that is super important, 100%. So thank you for.
There are policy issues. They're kind of apart from what we discussed normally, but in terms of advocacy, if you want to really have a conversation that makes sense and is informed, you should understand what it is you're talking about. So
Exactly. No, absolutely.
yeah. All right.
And
So
with,
starting with diagnosis,
yeah,
how do
and
you
with
have,
your experience, exactly. So with all your experience and your clinical experience, when it comes to mistakes that people tend to make after hearing about their diagnosis, what would you say is the most common mistake that people make right after hearing you have blank, for example?
if it's okay with you, I'd like to gently reframe the question. Um, Healthcare is a very emotional thing and a very personal thing, 100% of the time. So when you're a patient, you're sitting in that chair and someone says, this is what we're dealing with. This is your diagnosis. Um, that always hits. And it can be something as simple as high blood pressure
Yeah.
or sinusitis. But when you hear those terms, everybody's going to react differently. Some of them are going to act in a way that they're really capable of handling, and some won't have a clue, legitimately. I mean, it's not uncommon. And I don't want to sound at all sexist or misogynistic. This is what happens a lot in my life, especially when dealing with a male, a married male or partnered male. And he and I, and this is kind of funny, but it's true. We can have a very detailed conversation about you have this and this, and this is what we're going to do. And this is when we're going to follow up. And this is what we're going to watch. He'll go home and his wife will say, what happened? And he'll say, I don't know. And it's not just men. It happens both ways, but I see it a lot with
Oh,
men. But there's that when you can have a detailed conversation, you can think you've educated effectively, and maybe you haven't, but you don't know as a provider what you've actually accomplished sometimes. And there are also times, and this is well studied, but let's say I'm sharing with you that you have something really hard, like a cancer diagnosis or something an end stage diagnosis. As soon as I say you have breast cancer, something, your brain kind of goes into fight or flight. You
So,
get
yeah.
triggered, and nothing I say after that is going to land. It just won't. After that, you're not going to make memories. And you won't probably be able to sort out or solve problems in that moment. So if I'm giving you choices in that moment, you're probably not going to make them terribly reliably. All right. So let's go with an easy diagnosis that doesn't put you in that triggered section. Let's say you've come in with a knee injury, and uh, it's going to affect your work. It's going to affect how you function at home. You've got 3 flights of stairs, and even if you're young and healthy, you've got a knee injury. Okay, so I say I think you've got a torn ligament or ruptured disc, something, and um, I say we're going to put you in a brace, keep you off it for a week. You're going to come back. If you're still having a problem, we're going to get an MRI. Okay. Um, let's say that week is going to cost you a week of pay. I have to write you a note for your employer, or even put your job at jeopardy. Let's say um, the brace isn't going to be covered by your insurance, or it's not, or you're going to have to pay for it out of pocket. Um, let's say there are these barriers, there's implicit barriers in the course of everyday healthcare. Um, you're going to have to. So, in terms of what could be a mistake or a way to not function, would be to say, yes, I'll wear the brace, and then not buy it. Or go ahead and write me the note for work, but you're going to go to work anyway. Um, I know that happens a lot. What I would ask, and it's not a mistake to do that. It's not a mistake. It's how you're going to function and not feel like you're jeopardizing your relationship with me, right? Or not be embarrassed because you don't have the resources. The biggest mistake you can make is not being honest with me. I can't afford a week off. If I miss a week, they're going to replace me. Or um, I'm having more pain than I know what to do with, but I'm afraid to ask for narcotics because you're going to judge me. Ask for the pain meds, okay? Um, and if I have a problem with that, we'll discuss it. But if I don't know that's a problem, I can't address it. Can't afford the brace, can't afford the crutches. Okay, look, maybe you don't need them necessarily, but what can you and I do to make sure that you have whatever support, whatever comfort you need? Okay. So, and that's a simple kind of serious, but raises big problems, right? I have to come back and I have to do a copay, and then there's going to be a $3,000 MRI. How are we going to deal with all these things? If finances are a problem, please tell me. I may, at a hospital system, have resources, monies to spend for you. I may have a way to get you a free brace. I may have a social worker that can help you um, sort of navigate with your employer or with your HR office. So I may have resources that you're not aware of or that you're afraid to ask about. So that's in the short term for a simple, straightforward diagnosis. The more complicated diagnosis, bring somebody with you. Bring somebody with you. Um, I would rather have 2 or 3 people in the room for that discussion than one person who may not get to hear anything past the first few words I say. But that second person lets you answer questions, can reinform, can ask more questions that you're not capable of asking. And so that second person, even if it's a neighbor, even if it's someone from church, even if it's not someone terribly close to you, if that's someone that you can go to and say, what did he say? What am I making this decision about? So that second person, that witness, that advocate who will help you be your best patient, your best advocate for yourself, that is a very important tool. Um, so I guess both of those sort of speak to having a clear process and being completely open and completely honest and a little vulnerable. Now, as I'm talking through this, one thing that a lot of us don't recognize or somehow it's not on our radar is previous medical trauma. So let's say you've already had, let's say you're 60 years old, you've had a heart attack, you've had uh, a knee replacement, you've had a shoulder surgery, um, and you've had maybe one of those things have a complication. Just walking in the healthcare provider's door is hard for you, and asking for anything more is scary. So you may have your own boundaries around what you can ask for and what you can voice for yourself. I would going back to the our first conversation, before you walk out the door at the end of your clinic, please, please, please say, I don't feel seen. I don't feel heard. I need to say one more thing. If that's all the resilience you've got, just that line, I don't feel heard, will give your provider the opportunity to do the work they showed up to do.
Absolutely. And being that advocate for yourself to stand up and say that. And that's why I think it's so important. This podcast is so important to hear that from a provider. I have never heard that. And it changes, my perspective even. And I'm sure everyone listening has that a new perspective of just that something so maybe obvious or maybe not obvious, but something I don't think I had ever heard, and I'm sure most people haven't heard, just that one line can really change so much. And even though it may seem obvious, it may not if you've never heard it before. And having that thought process before walking out the door, just saying, hey, I don't feel heard, I don't feel seen, can really drastically change so much. And that also, I feel like, as I said that out loud, tied in so much to also having someone with you for a diagnosis. Because, like you said, in that moment when you're being told something, whether it's minor or major, you really do go into like fight or flight and you shut down, whether it's about you or whether even as a caregiver. I've been a caregiver before, and even though sometimes you're the caregiver for someone else, if you're intertwined with that person and you have a strong relationship with them, you can also go into fight or flight getting that news for someone else. So when you said bring multiple people, if you have more ears and more people, in a way can be super helpful, because when you're getting in that information and it's hard, everyone kind of goes into a little bit of a shock. So having someone be your ears for you is so helpful. So
Yeah.
I think that's just, super, super important. And
Well, and
going
it's hard too on the provider side.
right.
If I see someone with early dementia all by themselves, and I know that their partner, their whoever their caregiver is, wasn't able to come, I don't, I don't, I'm not going to be able to get a good history. I'm not
Right.
going to be able to get to do. I can do some care planning, absolutely. Is it ideal? Probably not. And will I be able to give that information to a caregiver in such a way that they can support them through the next piece of time while the care planning is going into effect, right? It's a challenge, but um, uh, I one of the things too that I was kind of thinking about while you were talking about your experience as a caregiver is there have been times when I'm talking to someone and I'm asking the questions and I've got a feeling there's something I'm not getting. I can just not get it, or I can say, I have done this. It changes the conversation and tone entirely. But I say, what am I missing? I have a sense that there's more here, but the questions I'm asking are not giving me the answers I think might be there. What
Hmm.
is it I need to hear? And it can be very frustrating, especially most of us are working in some kind of a production model. If we're in a large organization, which means we have to keep moving these rooms and moving these rooms and moving these rooms. So if I'm trying to get to something that will change things for you and I, and I'm not getting the answer, I often will cut to the chase and say, look, what do you need? Because I can't find it in the answers you're giving me. It's a
Hmm.
shortcut. It's just it's like playing shoots and ladders and taking the big slide. Let's go straight to the. It's helpful.
Absolutely. Absolutely. And when you're talking about these examples and having, someone come in and having them bring people or any one that you have in mind right now, but is there maybe a patient or a personal story that has taught you how crucial the first 72 hours can be post diagnosis?
Um, uh, the m- I'm not sure I want to put it in a window that tight, because it changes a lot if you're in a hospital setting or you're in an urgent care setting or a specialty setting, family practice setting. Um, so the certainly there are times, there are critical moments, especially in emergency medicine, where you've only got a short window to really make a change. But let's put this into a family practice setting. Um, and we're trying to keep you out of the hospital. Okay. You have an infection. There is something brewing that we know is going to get worse unless we really do a good job right now. Um, the big thing is that you understand what has to happen now. And you have to make sure, as a patient, and I'm putting the onus on patients, we do our best and we do screw up. I do screw up. But there are times when we're ordering medications, it gets sent to the mail order pharmacy, won't get there for 3 days, right? There are times when we send it to the wrong pharmacy. The previous pharmacy you sent it to is the wrong one, whatever. Um, there are allergies or some reason you can't take a medication that I'm not aware of. When you have something that is looming, that is going to get worse, and we only have a short window, it is critical that you get the visit summary printed and it's very clearly stated what's going to happen today, tomorrow, when you're coming back, when's the next set of labs, when's the next follow-up visit, when is home health going to call. You need to know exactly what's going on. You need to review it before you leave the clinic. And make sure the pharmacy is correct. Make sure you can get to the pharmacy and get your meds picked up. Um, make sure that the agency listed that's going to come to your house and take care of you is the right agency. These are all one of the biggest things that we do is that one of the biggest ways we have a miss is that we're not clear and we somehow are less than conscientious about how we implement what has to happen. Um, and this is one of the biggest reasons people get readmitted to hospitals. Let's say you go to the hospital, then you're sick for a week and you're there. On the way out, they'll give you a list of medications. They'll send stuff to your pharmacy. They'll communicate with your PCP. That discharge summary often is not well communicated, or not well executed. And the failures in that process of leaving the hospital is one of the biggest reasons you're going to fail at home and go back. So being sure before you walk out of any facility that you know exactly what has to happen is is one of the more important things you can do.
Absolutely. And I mean, I just went through an experience like that too, where I needed to make sure of every single detail before I walked out. And even after I walked out, I was still thinking, I should have asked this, I should have asked that. And I'm looking at the paper and it's like, I looked at all these things and I still don't feel clear about, X, Y, and Z. So I think that that is very important to really look over it and also take a second to let it digest because you can read through it and think you understand, but like actually make sure that you truly understand and are digesting what you're reading because it definitely can lead to so many other issues, like you said, readmittance or things like that, or getting home and not being sure of when do I take a medicine if there's a medication involved? Do I eat all these variables? So I think that having you know, a clear picture before you walk out is helpful. And then also if you have someone with you, if you're able to, then that's something that's super helpful as well because if you did just receive this diagnosis and it's shortly after, you can be looking through this and still kind of be in that fight or flight, that shock mode. So having someone there to also have a second set of eyes on that discharge paperwork is super helpful. And what mhm,
Well, and it's helpful sometimes if you, most of us don't have time to do this, but let's say you make a plan with a patient in a family practice clinic and you as the provider understand it completely. If you say, okay, now I'm going to ask you to tell me what you need to do or what's going to happen for the next 24 hours. If the patient can't very clearly give you back, reflect to you the same thing you have in mind, there's more work to do.
mhm,
There's more explanation. There's more work to do, and you can have if you have a staff member who understands the plan, spend time and get it clear. That's a tool. It's very helpful sometimes too. But
absolutely.
yeah, and we can document. I can document that I explained all this. But if you
Mhm,
don't, and I can say that you asked questions and I answered them. That doesn't mean you really understand. So I can on my side I can say, look, I did my job,
mhm.
um, which makes coming back and saying maybe it didn't very difficult. But um, anyway, so patient's perception, patient's ideas, patient's reality needs to be consistent with the plan. And if I haven't if I haven't been diligent, I can miss the opportunity or miss the chance that this will go well.
Absolutely. And what would you say are some non-negotiables that every patient should document right away? Labs, visit notes, timelines, insurance contacts.
Um, most patients are able to see, well, theoretically, everybody should be able to review their electronic medical record, um, and uh, be able to say, this is accurate, this is not. What the tool that I would recommend is messaging through my chart or something similar to my chart, back to your provider. That's not what I said. That's not what I heard. That's not what I came in for. That's not the diagnosis you told me. When you send those messages to the provider, they become part of your record. So you can dissent right there in writing as a way that will permanently be part of the record. That can't be deleted. That's part of it. Okay. And that's a very good way to document things as well. So that if you have several different problems, several different issues, several different headaches, um, that information is all coming back. And let's say your grandmother is 78 years old and has never used a computer, doesn't know how. You, as a family member, can be listed as an agent on most medical records, and you
Oh,
can have access to send those messages as well. Um, and the meds didn't get to the pharmacy. You can send the message. The referral didn't go through or went to the wrong place. Send the message. Went to the wrong place. Um, Medical assistants and providers and whoever else is touching that chart does have a window wherein they usually are obligated to address that issue. And then they'll respond in the same way. So you get this nice documentation line by line.
mhm, absolutely.
So
No,
yeah,
that's so
that's a
important.
great way to start the documentation process.
Absolutely. And I know you've said this previously that the chart belongs to you. And I think everything you said really sums up why record ownership really does matter so much because it just gives you that trail and that documentation to really clearly have, not a blueprint, but have uh just a record of every single thing that has happened and as the patient or as the advocate to just have proof that this was communicated to the practice and the provider has the option to really be able to connect back and so just so that things have clarity because in these instances and these scenarios there's so much that can get lost in communication kind of what we've been touching on so having that clear record is so important for all parties involved so it's good advice, especially and that's good information to know that someone can, um, go into the chart, for example, like you mentioned the grandmother and having, a family member be able to have access to that chart because of I think that that might not be super well known that that is an option because a lot of people think, oh, HIPAA, that's their information. I might not be her proxy or she's competent and this is her access. So having that information is super important. Thanks for sharing that because I'm sure a lot of people don't know that. As
Sure.
someone who was a caregiver to my grandfather, I didn't, I mean, I was his proxy, so it was a little bit different, but having known that information then could have been helpful because maybe someone else could have had been that second set of eyes for me to look through everything and communicate. So that's super, super valuable and important. And in terms of, mhm,
No, oh, as we're speaking, it sounds like I'm like, "Go get your provider." That's not
no.
when I say things like, "This medical record is something for you," it's something for you and your provider and everybody else involved in your care. The goal here is not to be defensive and triggered all the time. The goal here is if you're advocating for yourself and you're sending messages, you will have the best possible outcome. And to ask your provider to be accountable, to be timely, to follow through, to make the changes necessary. That's you and the provider working together as a care team.
Mhm.
Certainly, there are times when it's like, come on, guys, I've asked for this 3 times. Could you at least send me a response? Okay, then that kind of emotion is worthy. But yeah, I would like to see this more as a correlation and a compilation and a kind of a coming together as opposed to
Mhm.
going at and coming back. Is that fair?
Exactly.
Okay.
Absolutely. So it is a team because it is your
Absolutely.
healthcare team. So
Mhm.
having everyone on the same page and just being able to not have to, for example, someone who's worked in healthcare and somewhat administrative, when things aren't noted down, did you call this person? Did this person reach out? Did they get a response? So sometimes it's easy for things to, in a way, fall through the cracks. So just sending those messages and having that clarity is just helpful so that all parties involved are on the same page and it makes it easier for everyone to work together. And anyone who has worked in healthcare understands that things are fast. So just taking a second to just write down that quick note instead of, not doing it and just thinking you'll remember, thinking you told someone or those things can happen. So just having that clear track is just like we said, teamwork for everyone involved to be able to be as helpful as possible. And the patient can definitely get the best care when everyone's on the same page and not feeling that stress of trying to figure out where things are or what happened. So it's definitely important. And as we're talking about medical records and note taking, what would you say are some practical tools that help in terms of maybe digital portals like we mentioned, but aside from that, maybe shared folders, binders, caregiver spreadsheets. Are there any other practical tools that you find helpful?
Um, I will say that there are times when a patient comes in and they've got their notebook and it has their blood sugars and their blood pressures and their heart rate and some people are incredibly gifted at documenting what's going on with them. Um, that if you walk into my clinic with that notebook, I'm in heaven. Oh my gosh, what a gift that is. Holy smokes. Yeah. Or you come in and you're documenting your weight very carefully because you're on a weight loss regimen or medication, or you've got chronic headaches and you bring your headache journal, and I can see what you've been eating and drinking and how you're sleeping, and we can work on how this all goes together. Um, those things are amazingly helpful. And if you're not that person, maybe your support person could be, right? Maybe it's the grandchild that lives with you, or a daughter that checks on you frequently, but who is documenting.
Hmm.
Um, those things are priceless. Uh, a lot of that stuff comes in an analog fashion, just generationally. There's a huge population out there that is unfamiliar with using computers, and so. But even the handwritten stuff, we can scan that into a chart, and we can refer to that later. Um, that's beautiful, man.
Hmm.
That is a treat when we see that. Doesn't happen as often as I'd like. Um,
Hmm.
but one of the things too that's been helpful lately is that we're seeing things like continuous glucose monitors. where we're down to every couple of minutes, we're getting a really accurate reading of blood sugars. And we're seeing how sugars trend, and what happens when you take your medication and when you don't, and what you're eating. That kind of stuff is amazing too. Um, and then, of course, everyone's probably becoming more familiar with the wearables, the ring, the Apple Watch, the Whoop,
Fitbit, kind of.
all of those things. If you bring your phone and I get to see, we get to look at how you've synced everything up, man, that's valuable too, especially for things like sleep, because most of us are not good at assessing how we sleep, when we sleep, how the quality of our sleep. But while the data is not perfect, it's way better than the patient telling us what's going on sometimes. So that data, bring your phone, let us see it. It's really helpful for sure.
Mhm. And I think it just sounds like also in terms of the patient or the caregiver, whatever works best for them, and just documenting as much as you can in whatever way works the best for you. Just trying to really be on top of tracking it.
Well, and think about if I'm asking you questions about your blood sugar, but you didn't bring your log, you didn't bring your blood
Yeah,
sugar checker, and you've got a vague notion, that's fine. That I can work with that. But if you bring me 800 blood sugar readings and graphs to say what's going on, think how much further ahead that puts us in the conversation. That launches us miles down the road and saves tons of time and gives incredible clarity. So those tools, if you can get the, and if you're diabetic, please ask your provider for the continuous glucose monitor. You're not going to poke your fingers as much. It's not going to be as uncomfortable, and we're going to get better data. So these are very helpful tools. Super helpful. I'm glad you asked. Thank you.
and I'm kind of laughing and smiling just because I remember my grandfather documented everything. Like he, as someone who was a caregiver for him, he truly did make that aspect easy. I mean, he had this notebook, which I still have. He wrote down every single thing, every single medicine he was on, patient he was on, the time he took it, if he took it in the morning, the afternoon, the night. He had all his pills labeled and what time he needed to take things. So as a caregiver, that was so helpful for me. And in terms of caregivers and family members, what would you say is the role for the caregiver in terms of how they can help without overwhelming the patient?
That's probably a case by case thing because a lot, and even week to week, that can differ. There are some folks that welcome the support and welcome and want the help and the input. And there are folks that have been living their life the way they've been living their life for decades and decades. And why all of a sudden is this necessary? You know? So
Mhm,
it's really variable. Um, where I find the caregiving support to be most helpful in my role, in my clinic, uh, is just that extra bit of reporting. Most of us as patients have some blind spots about how our health is going, how we're taking care of ourselves. Most of us are accurate to a point, but there are a number of things that we don't see or hear and can't know. So to have someone else along to say, okay, you didn't shower all week. We just showered before you came to the clinic. Okay, that's a level of function that I was not aware of, right? And that tells me a lot that the patient wouldn't have. So, uh, as far as how the caregiver and the patient get along outside the clinic, I wish I had some amazing insight to be helpful there. It's going to be different from person to person. Where I often see challenges is in I see this pattern, and it's not we all see this pattern where someone with dementia and their spouse are always together. The spouse, the caregiver, is somebody I'm more concerned about, almost legitimately, than the person with dementia. Because the spouse, the caregiver, has to give 24 hours a day. And they somehow have to do the grocery shopping, and they somehow have to pay the bills, and they somehow have to wipe butts, and they somehow have to do all this stuff. And there's no way this person will give themselves a break. Even when friends and family come and say, "Why don't you go take 4 hours to yourself?" They won't leave. The caregiver is absolutely tied and duty bound to their dementia patient. So my job is to take care of that person as much as the person with dementia. So that's a role where I do try and step in on a frequent basis to try and give some respite to the caregiver. Um, and I do, in that case, give advice. We need to take breaks. We gotta get you away for the weekend. How are we gonna do that? What can I do to help arrange care for the pets? Or what family member can I call and ask for more support? Those are those are ways that I can help in that circumstance more than most, honestly.
Absolutely. No, it's the role of caregiving is so complex because you're doing everything to take care of this person. And it's so easy to lose sight of taking care of yourself. And you need to be taken care of in order to take care of someone else. And that's something that is very, very difficult, especially, well, not even especially because they're in their own respect super difficult, whether they're in a hospital or a home or they're at your home. It's hard. And you always feel some sort of guilt about leaving them. Are you doing enough? And it's just so easy to
Exactly.
forget to take care of yourself. So absolutely. And then this is just the caregiving aspect we're speaking of in regards to the day to day and the patient and, making sure that they're okay. And we're kind of focusing on the day to day. But beyond that whole role, part of the caregiving is the admin things, like you said, even groceries, but beyond that, like medical bills and insurance. And that is a whole nother headache that the patient may not be going through, but dealing with because the caregiver is dealing with it. And it's so complicated. As someone I can say from experience, it's so
Tremendous.
complicated. But
Right.
mhm,
Yeah,
what
just
would you
navigating
say?
healthcare for someone who's not the patient. Yeah, exactly.
Yeah,
This
absolutely.
whole navigation piece that we're gonna work into over time, yeah, it's more and more difficult. And I'm nervous about the future. To say I'm scared might be overstating it, but we're gonna see more and more people becoming caregivers. If what we see coming down the line, politically and financially is real, when clinics are closing and nursing homes are closing and hospitals are closing, more and more of that work is gonna fall on family. Now, that may or may not be
Absolutely.
a good thing, but there are gonna be a lot of people who are not caregivers now who will be immediately transformed into that role. And how do we support them the best? That's gonna be a new challenge for people in my role.
Mhm.
It
Absolutely.
it's gonna be huge. So,
Absolutely.
I think that's I'm gonna have to learn, and I'm gonna have to grow into this role as more and more people are in this role as a supportive person for everybody else, uh, who are doing their best. Um, I I'm eager to do that learning, and I'm scared that I'm gonna have to.
Mhm. No, that's something I hadn't thought about, but it does make complete sense. And it's gonna be a learning curve for you as a provider and for those people who are going to either be voluntarily stepping into those roles or maybe even forced into those roles. And in terms of that change and in terms of what we were talking about in terms of handling the admin aspect and the bills, how can patients or caregivers kind of get clarity on what is covered versus what's not covered before those bills really start to come in?
Yeah. Wow. That's probably a bigger question than you can imagine. Um, well, just it's it's ridiculous. It's stupid, and it's designed to be. And here's where the energy comes because let's say, in Oregon, I live in Oregon, I work in Oregon. Right now, if you are on Medicaid and there's a problem, or there's something needs to be prior authed or is being denied, refused, your doctor doesn't have any way to advocate for you. You, as the patient, have to do it on your own. Tell me, does that make sense? And the
It's
first few
horrible.
phone calls you make, the first few emails you send are going to go to somebody who has zero medical training. This is somebody who is somebody who answers the phone and does some data entry and then maybe sends it up the line. But there's an algorithm that they're going to put your information in. And if it says no, the answer is no. Okay, there may be a chance for appeal, but it's not going to be an easy process. Now, you can still ask your healthcare person to help you, to support you, to answer questions for you so you can be the advocate, but this is the frustration. The way Medicaid works is that most of the Medicaid policies that are written are managed by private companies, so private insurers. And the private insurers have made this so impossible and so hard to handle that they know you are going to give up. Okay. When you get to the place where you've hit your head on that brick wall enough times, call your doctor. What do I do? A lot of us have people on our teams like social workers and people who are RNs who do nothing but make these phone calls and find these solutions. Now, the nice thing about those people is that they have networks. They they've got phone numbers you don't have, right? They've got email contacts you can't have. So there are still ways around that kind of headache, but just because, and that's just Medicaid in Oregon, all right? There's almost any insurance plan you call. How long is your wait time? 45 minutes to an hour. Reasonably. Then you get somebody who can't help you or who will tell you, oh, the expiration date on this appeal was yesterday, right? Call your doctor.
Or the call
Basically,
drop.
yeah, right. So basically, there's this entire system of insurance and PBMs, prescription things, and and there, there's this whole system that you don't know about and can't have access to. Then there's you and me. This is where we are. There's this whole rainbow of problems that we have to try to push into to get what we need. So you're making these expensive premium payments all the time. You're making copays, and you can't have what you're paying for. That's where we're going. But that's the work we have to do. Now, I just went off, and I'm not even sure I answered the question. Your question was, how do we do this? Well, okay. You've got an insurance card. On the back of that card, there's an 800 number. That's where you start 100% of the time. You can also email. A lot of these systems have chat bots that you can sort of start working with too. But the 800 number on the back of the card is where you begin. And then they'll give you new numbers. They'll tell you yes or no. They'll move you forward. They'll say you need to talk to your doctor. I don't know. I could talk about the answer to this question all day. There is nothing I can tell you that'll be easy or satisfactory. There just isn't. And it's designed that way. It's absolutely designed to make everything impossible to get.
No, absolutely. Absolutely. I thought of you the other day. Shortly after our first episode, I had a day with just trying to I just had my annual and I was needing a prescription and it took me maybe 6 to 7 hours to just navigate that. And it was so stressful. And I kept thinking about how it was so like related to our conversation. And I'm relatively young and healthy and going through just a regular annual and oh, they want to do an echo and all these things. And do I really need this? How much am I going to pay for this? What I'm going to walk out and are you going to tell me I owe $400 that should be covered by my insurance for an annual because you decided you want to give me an echo and all these things, right? And I don't know if there's something that if you would be able to answer this, but how do you think that patients can kind of identify red flags early on? For example, like coverage gaps or referral bottlenecks or, a way that they can act before the crisis hits?
Yeah. I think it's safe to say you should probably anticipate paying for everything until you know you're not going to. I just think that's how I approach it as a patient. Um, even when things, recently, there was just news last week that Medicare is going to start covering the weight loss injections like Trulicity, Wegovy, Ozempic. Well, okay. So in my world, we're like, yay, I can get really amazing benefit to a whole lot more people right now, right? Okay. So order the medication, send it out, um, get it approved after the headache, right? The phone calls, the prior auths, the
Mhm.
refusals, the appeals, get it approved. And then Medicare is going to pay for it, right? Super. If you're paying cash for it, it's going to be $1,100. If Medicare pays for it, it'll only cost you $950. Okay, so it's on Medicare. Medicare is going to pay for it. They're going to pay
Mhm.
$150 for it, maybe. You're still on the hook, and you're still not going to get that drug. So this is what we're up. This is what we face on a routine basis now. Uh, so, but this is why I want to do what I want to do. This is why we're going to build this process. This is why we're going to put tools together for people who need them. Um, now, that little thing is something I'd like to work more on. It's just a week old, so trying to sort out how that works is still in the process.
Mhm.
Maybe more soon.
Absolutely.
Yeah.
And even speaking about that, with certain medications being covered, um, whether it's like you said, $150, or then there's someone who can get it for $5. And it's just like everyone needs a certain medication, and it's so unfair that some people have to pay $1,100 and some people have to pay $5, they are both technically covered. So that's even super confusing to navigate in itself. And that just made me think of it because I know someone who took Wegovy and she paid $9 for it. And I know people who needed it as well and they were having to pay like the $1,150. So it's just so, and those people that, like you said, have to pay $1,150 were told, oh, it's covered. So you're thinking it's not only $150 that's covered. So it is super hard to understand and
Right.
navigate.
Well, and as a provider too, when I'm prescribing,
Mm-hmm.
I have tools in my medical record that sometimes will tell me this is a high tier drug. It's going to be expensive, or they sometimes will tell me this drug will cost $4. Sometimes the tools actually give me some idea what your policy will accomplish. Sometimes they're wrong. So if I say, "Oh, the computer says it'll cost you $40," you might find at the pharmacy it costs you $2, or you might find it costs you $100. So even as a prescriber, with the tools I have, I probably am not going to be accurate in understanding how this might affect you financially when I'm ordering something for you. Yeah, it-
Absolutely.
it's something to sort out.
It's so confusing, and it's just such a influx of information that you never even know if exactly what is reliable to the degree in which it needs to be. So I think that's just and I've never thought about these scenarios from a provider's side. So it is so interesting to hear that and understand what tools are there, and even the tools that you have may not be always reliable. I know at work in the admin side, you would tell patients this and just like, oh, I hope that's right. I hope that this is up to date. And I never realized from a provider side that it's something, you may not know either is the validity of it, right? So it's
No,
just
I
interesting.
think patients have an expectation that I have some very real idea, and that I know exactly what's going to happen when you go to the pharmacy. I think that's probably not realistic, um, and
Mhm.
setting the expectation for patients is very important too. You know, uh, it, it's a common conversation that I've had with patients that, look, this is what I'm going to do. This is what I think is going to happen. If it doesn't happen that way, call me right back, or come back to the front desk. Let's work it out. Um,
Mhm.
yeah, there's a lot to talk about on the provider side. And I know we're going to sort of wander away from the questions that might be more apt to be that we kind of initially kind of considered, but let's do that. Let's wander for a second. That's okay. One of the things you're going to see, and have seen, absolutely are seeing every day, is that medical staffing is not adequate at all. There are not enough providers. There are not enough nurses. That's true. Also, there are fewer people going into medicine, fewer people graduating medical programs, and um, and people like me are having shorter careers. So an ER doctor's life expectancy, a career expectancy is something like 10 years. That's after how many years of training and residency and fellowships and all that. They're going to work for maybe 10, 12 years, and then they're done. And a huge, huge part of that are the problems you and I are discussing right now. In order to take care of, say, 20 patients in this system, as it is, with the complications we're discussing, it's going to take me something like 6 to 8 extra hours of administration if I do it well, answer all the questions, get everything right, sort out all the problems downstream, and still somehow chart all that. I don't have enough hours in the day. And I didn't go into medicine, by the way, to deal with this shit.
Mhm.
Apologies.
No, it's
But
true.
that's what it is. It really is just that. I didn't go into medicine to become a data entry person for an insurance company. I didn't. The time I spend face to face with patients is where I get my joy. It's why I get out of bed in the morning. And I can't do that without the rest of this. I can't. It's part of the job. It's also part of why a lot of people don't want to do it. So we're talking about what happens from the time of diagnosis to the time we encounter insurance issues and so on, and how you're going to make the most of this. It's really important. I think let's just take a step even before that. I think the relationship that I have with my patient is the reason I will go to bat for that patient. It changes my investment in the process. And it's not right or wrong that that's real. It's human that that's real, right? So when you come and sit down in front of me, let's really communicate. Let's really bring it. Let's really be square. Let's start the entire relationship on solid footing, and let's work together. And where we bump into things that don't work, let's be kind and constructive. And I will bring my piece if you let me have it, and I will let you have your piece as we move forward. We have made healthcare such a commodity that we have really reduced the people involved in it to someone like a bad waiter. If you want to send back the chicken every time I bring it out of the kitchen, guess who doesn't want to bring you the chicken?
Mm.
I'm not saying I wouldn't take care of you and not give you my best. There is this thing called standard of care that I have to meet. So if you show up with this problem, I have to address this problem in such a way that we work toward outcomes in a safe, healthy, well-studied way. That's my job. And I will do it even when we're at odds. But I promise you, if we can both be human in this process, we'll stay in that process together longer and safer, and we'll probably have better outcomes in the long run. I don't know.
No, that's absolutely
This is
true.
the energy thing that I just can't get away from.
No, it's true.
Yeah. Anyway, I genuinely grow so much from those relationships, and I hope my people grow as well. And there's something I get out of this as a provider for sure. Um, and when the business side and the technical stuff and the frustrations come, it really reduces my reason for being involved. So as healthcare becomes more challenging and fewer people involved, if you can actually connect to somebody, gosh, you have lassoed a resource that will be invaluable. So anyway, there we go.
No, no. No, it's just so funny that you speak to these topics and I just keep getting like memories of my own. And it's true. When I was a caregiver, I built such a good relationship with a few of the advocates, and a lot of that was my grandfather and how truly funny he was that everyone, the patient advocate on the floor, came to his services when he passed because they had such a good rapport. And I was connected with her so well that you're gonna get my grandpa another ice cream later, right? And just like she would be the one to call me and let me know those specific things in terms of, oh, the bills. It was just really good to have that connection with, for example, a provider or an advocate, or, it is that human aspect. It is that energy. It does go so, so far. And having someone on your side is always, always going to be helpful. And like you said, be honest with your provider and, let's go, let's sit down, like that face to face initiation and contact with your provider and that relationship is helpful. And it is, like you said, it's human. So just being able to have that connection and build that rapport, especially you're a provider, you obviously care so much about people. So if someone has a provider and just, you know, may not feel comfortable with being honest or saying, "Oh, I'm fine," or this and that. Just being honest and open and building that relationship does really sound like something I've never thought about, but it's so true, and it can go so far. And we'll tap into more resources, and it could only help. Essentially, like there's definitely no harm in it.
When we put
And
a label on that, we call it a therapeutic alliance.
I like that.
Yeah, truly an alliance.
That's
And
true.
it's hopefully therapeutic. It is fair to say that I say, I don't know, the data moves around a lot, but something like 70 to 80% of the reason you are in a clinic at any given time, 70, 80% of the reason you are there is emotional.
Hmm.
And if I, as a provider, I mean, yes, there's health issues. Yes, there are physical problems. I get that. But the data is 70 to 80% of the reason you show up is emotional. Okay. If I, as a provider, look at your blood pressure and just say, take more medicine, I've missed the anxiety. I've missed the insomnia. I've missed the social stuff that goes with, right? But if we can be open and honest about what's real for you in your life, you know, then I can address this entire process very differently, right? So, um, when patients, I think a lot of patients believe that they are a commodity, and we've designed systems that make that real. Um, when we can both be human and both show up, we have a very real chance at a better series of outcomes, no question.
Absolutely. And going back to earlier, how we were speaking about bringing in outside help with advocates, navigators, when would you say is the best time? So, when should someone really bring in an advocate or a navigator or support organizations? When would you say is the best time for that?
In that moment when I ask you, okay, I've outlined what I think we need to get done. What do we, can you tell me what that is? If it doesn't come back clean, that's a good time. When someone has multiple medications, let's say more than 5, they should probably have somebody who's willing to go over them, make sure the refills are on time, make sure the pill bottles are set up, whatever. Um, if someone has a referral process that's slow or multiple referrals, that's a good time. Um, and if someone's beginning to fail and doesn't have much support, we see someone who is using a cane now that wasn't using a cane last time we saw them. We see somebody whose hygiene is slipping. That's the time to bring somebody in. When those little, small steps toward a failure are something we perceive, that's a great time to get someone with those skills and the time and the job description to go into that place.
Absolutely. And in terms of clinicians who are listening, our providers who are listening, what would you say are some small changes that could really make patients feel more empowered from the start?
Uh, that's a big one. It's so hard. Um, Big systems mandate you spend this much, that you do so much in a given piece of time, that doing more is difficult, but changing the approach might be very helpful. I work with a lot of doctors who are very much, you will do it my way. You will visit when I say, you will do your labs when it's time to get them done. You will take your medications as I prescribe them. Okay. That worked 50 years ago, right? You and I are now informed consumers. You and I now have options. You and I are going to look for ways to not be treated like that. No one wants to be treated like that anymore. And so if that's still the method that you and your organization employ, okay, you're going to have failures. But so one of the things, especially when I was really fast paced working, was, all right, I'm about to walk out the door. Have you said everything you need to say? Or have I heard everything I need to hear? Is a very different way to exit that room. Or even at the outset, like the very beginning of the conversation, look, I only have a short piece of time here with you today, and I want to make the most of it. What's the most important thing I need to hear before we're done? Instead of, your sugar's too high, your blood pressure's too high, you're not taking your pills, blah, blah, blah. It is, look, I've got all the data. I can make some changes if we need to. What are you bringing? That's the most important thing right now. It changes the entire tenor of the conversation. You will have to ask many fewer questions. You'll have to make fewer guesses. You'll have to infer less. What's the most important thing? And then at the end, is there anything else I need to hear? Oh, it's a different series of expectations. And the next time that person comes to you, the conversation will be different as well. You will condition your patients in a different way to be better, to be a better part of that therapeutic alliance.
Absolutely. Absolutely. It's a game changer for, I think, both the patient and the provider. So I think that that is amazing, amazing advice. And I know any provider or clinician that's listening will kind of, I would imagine, like, wow, great advice. So I'm hoping that everyone who is listening really, really takes that into account. And I think that that was great advice. Also, I think this was such a good episode. I think this was
Oh, good.
so, so great. I think it was very powerful. This has been a powerful reminder that advocacy really begins the moment that we start asking questions. So, for anyone who is listening, who may have just received a diagnosis, take a breath, grab a notebook, and remember knowledge is your first tool. And documenting is also something that we spoke about today that is super, super important as well.
Well, I would say if you made it into a family practice clinic and you had vitals and sat down and were ready for the conversation, you are already an effective advocate for yourself. You're already asking for what you need. In this day and age and the way our healthcare system is built, I want you to keep asking and keep asking and keep asking. I would rather answer your questions than miss the chance to take good care of things with you. Absolutely.
Thank you so much. This was, I think, so powerful, like I said, and very informative. And for everyone listening, this is episode 2. This is Care on the Line, where every episode moves patient from reaction to action. And I cannot wait to talk to you again on episode 3. And thank you so much, Micah. This was great.
Appreciate your time. Thanks for being here.